There you go. You should be co-host now.
Okay, thank you. So we're officially recording.
Yeah.
My research assistant, I don't know if is Maddie on the phone or is she not with us yet?
I don't think she's come in yet.
Let me just send a quick email to her. I'm pretty sure she'll join us. Sometimes the Eastern time might have thrown it because it's 2 o'clock Eastern time.
Yep. Tammy, how are you?
Hi,
Hi, good to have you with us.
good. I'm sorry. I will have you on mute and video off because I have a 4-year-old in the background. So,
That's fine.
okay. So I don't interrupt, but thank you for
Yeah.
having me.
Yeah, glad you're here.
Lenny, you have a beautiful backdrop.
I know.
Love the
Yeah.
windows. Looks like you're in a cathedral. Beautiful.
It's kind of like a cathedral. It's probably the nicest building at DePaul. It's just a background. It's I'm not actually there, but
Well.
all the presidents have their pictures there, and it's where different ceremonies at DePaul occur. It's built in British style.
Nice,
Beautiful.
nice.
And for those of you not in Chicago, DePaul is a beautiful campus. It really is. It's right in the heart of Chicago. It has lake access and it has beautiful buildings. It's really a magnificent location.
So Sally, where are you that you're going to be permanently in snow? I'm trying to get my head around the whole of this, where everybody is.
Homer, Alaska.
Oh, okay.
Yeah, yeah. Yeah, we've had a better than, oh, this is more like normal used to be. We haven't had much snow in the last few years, so this is normal.
Oh, okay. Bit more than over here, I suspect.
Lenny, have you done have you spent your whole career at DePaul?
This is my 46th year.
Wow, wow, that's impressive.
I started when I was 2 years old. So
Of course.
That's great.
And he has pretty much made the whole department of his community resources. So I mean, it's all Lenny Jason's doing. So it's pretty impressive there.
That's exciting.
it's either doing or undoing. I'm not sure which one goes with.
Oh,
it, but,
you've made it.
one of the two. You know, I'm happy. Again, it could very well be that Maddie got tied up, but I do have a presentation that Maddie and I prepared that I can give some slides. So you tell me, Amy, when you want us to begin this thing. We could do introductions to start as well.
Yep.
Whatever you think would be best.
Yep. I will introduce Maddie just as if she were here also, and then so then we'll hand it over to you, Lenny. Okay.
Sure.
So. Is everybody ready for this journal club?
Yes.
Okay, so thank you all for joining us. It's really good to see you all and see your smiling faces. Today we have a very special guest, and hopefully the co-guest will join shortly. But Lenny Johnson is a current professor of psychology at DePaul University, which is in Chicago, and he's the director of the Center for Community Research. Dr. Johnson is a former president of the Division of Community Psychology of the American Psychological Association, and he has edited or written over 30 books. He has published over 800 articles and 100 book chapters. So he is an amazing writer. He has served on the editorial boards of 10 psychological journals, and he has served on a review committees of the National Institute of Health. He has received over 46 million, is that correct?
Are you sure it's not 1,000?
40, okay. 46,000 in federal research grants. Does that sound more accurate?
I was just joking. It actually is 46 million. So
That is impressive. So $46,500,000 in federal research grants. Our next guest is Madeline Johnson, and she is the current research assistant at DePaul Center for Community Research. Maddie graduated in 2018 with a BA in developmental psychology from the University of Illinois, Urbana-Champaign. And upon graduating, she was awarded the High Honors Distinction by Psychology Department for her completion of an outstanding undergraduate research thesis. Maddie is primarily interested in the psychosocial outcomes of children with chronic illness conditions and their families. She is also interested in the role of medical communication that plays in treatment of disease process. So welcome, and Lenny Jason, we will let you take it from here.
okay, and I'm going to share my screen so we can, and I'm going to pull this up. So I have several slides, and can everybody see this okay? Good, okay. We're going to be talking about post-exertional malaise. And there's a couple different definitions of it, but it's a hallmark symptom of ME/CFS. ME stands for myalgic encephalomyelitis, CFS for chronic fatigue syndrome. We think that this is also one of the primary symptoms of the long haulers. So the Canadian consensus criteria, which came out almost 20 years ago, basically defined this post-exertional malaise, we call it PEM for an acronym, as an inappropriate loss of physical and mental stamina, rapid muscular and cognitive fatigability, and the tendency for other associated symptoms to worsen. Whereas a more recent Institute of Medicine document said it was prolonged exacerbation of a patient's baseline symptoms after physical, cognitive, orthostatic stress. It may be delayed to the trigger, relative to the trigger. So those are some classic definitions. There's lots of ways and lots of terms, lots of different variations of this term, but I think it's mostly referred to as PEM. Our group developed something kind of a number of years ago with something we have called the DePaul Symptom Questionnaire. And within that DePaul Symptom Questionnaire, we had a set of items. And these are the items here. A dead heavy feeling after exercise, muscle weakness even after exercising, next day soreness after everyday activities, mentally tired after the slightest effort, physically drained after mild activity. And the NIH CDC's Common Data Elements working group, actually, which I was not a member of, recommended that these particular items could be used in a two-step process. One is to determine whether a person has the frequency and severity over a 6-month period. And you can see these items. This is what it looks like, frequency, severity. And you can see, usually we think of a 2-2 as being critical, about half the time in frequency and about moderate severity. So if you start getting a 2-2, which means half the time in moderate severity for any of these 5 items, we say, well, you probably have some semblance of PEM. In addition, we have other questions on our DePaul Symptom Questionnaire that we would say in a second step would be used. One is PEM duration, and these are items, do you experience a worsening of fatigue energy after engaging in minimal physical effort? And after, and if they say yes to either of this, they're presented with the question measuring PEM duration. If you feel worse after activities, how long does this last? Measured in number of hours. So that would be duration, okay? And for quick recovery, if you were to become exhausted after actively participating in extracurricular activities, sports or outings with friends? Would you recover within an hour or two? And this is helpful in assessing triggers other than physical activity. So duration, recovery, and exercise exacerbation. If you do exercise, is it because exercise? If you don't exercise, is it because those exercise makes your symptoms worse? So this is helpful in identifying patients who already modify or eliminate activity to avoid PEM and thus may appear as false negative on a PEM subscale. So this was like sort of a quick way of looking at PEM, which is really somewhat brief with just 5 questions and a couple follow-up questions. And these are the follow-up questions, which again, those first 5 and these second 5, a 10-item scale, and it's very brief. And with this scale, we were able to really make about 80% distinguishing ME/CFS from MS and post-polio syndrome. So, and the PEM duration question was flagged as the factor really differentiating ME and CFS from MS and PPS. So that duration is one thing that's different about basically ME/CFS is that, you know, yes, post-exertional malaise does occur with polio and post-polio syndrome, but the duration in ME/CFS is much longer and can sometimes take, you know, hours and hours and days. And that's really one of the key differences that we found in the study that we published in 2018 by Joey Kotler and others. So what happened was in 2017-18, this particular group from the common data elements from the CDC, NIH, talked about these criteria as being something they wanted to include. And a lot of patients responded saying, well, that 10-point questionnaire or those items doesn't really get at the real details of what PEM really is. So I threw a challenge out to the patient community through my website and my Facebook page. And I said, well, why don't we create a real instrument? Because the Paul Symptom Questionnaire is for all the symptoms. And we just took out a couple for PEM. We know that PEM is really a lot more detailed. And over the next 6 months or so, we really created multiple incarnations of a new instrument. And it was actually patient driven. So the patients, in a sense, really came up with most of the ideas and the items that basically became part of this much more thorough questionnaire. And I might say, this is one of the few examples of really patients helping create an instrument on one of the critical dimensions of a particular illness, in this case, ME/CFS. So this instrument had, in a sense, 6 parts. The first part, real basic demographics and illness duration. Second part, onset and triggers. Third part, consequence and symptoms. Fourth part, symptom list. Fifth part, duration, recovery, and pacing. And the 6th part was physical functioning scale. So in a sense, this is all the different parts of this questionnaire. We'll go through each of them real briefly. So as you can see, demographics is on the left, age, gender, race, things like that. And then on the right, you can see illness onset. So we just asked very specific questions about the illness in terms of, you know, and also how incapacitating a person might be in the last 6 months. So these are basic questions that we ended up asking everybody. And then the second is onset and triggers. And onset is, for example, is the onset of your symptom exacerbation ever immediately after exertion? Or is the onset of symptoms ever delayed after exertion? So sometimes it's immediately after. That's one of the interesting things, is that sometimes it's really a delay after an activity that the person feels is PEM. So onset questions were one set of issues. Triggers is another set of issues. You know, what is it that basically triggers the PEM? And is it basic activities of daily living? Is it positional changes? emotional stress. And really, sometimes it could be, for example, things like chemicals, foods, light, heat, noise. I mean, lots of different things seem to be triggers for this illness, which again broadens the concept of post-exertional malaise. So in terms of all the different things that can precipitate it. And then what are the consequences? If you get triggered, what happens? And we basically say, if you go beyond your energy limits by engaging in pre-illness tolerated exercise or activities of daily living, do you experience any of the following? And then these are some of the things we would ask them, do they experience these things? An abnormal response to minimal amounts of physical and or cognitive exertion, an onset that is immediate or delayed by hours or days, a severity and duration of symptoms that are out of proportion to the initial trigger, a loss of functional capacity and or stamina, post-exertional exhaustion or symptom exacerbation. So this is the symptoms that we ask. And again, we could have asked many, many symptoms, but we thought that these were some of the key ones. And for each symptoms, we asked them about the frequency and the severity that they occur. And again, we usually think about a 2 about half the time for frequency, and a 2 of moderate severity as being helping us differentiating when it really meets criterion for a serious symptom. Section 5 is duration, recovery, and pacing. So duration recovery is in the first column on your left. And does your prolonged, unpredictable recovery period from symptom exacerbation last days, weeks, or even months? If yes, how long? Is the severity and duration of the symptom exacerbation out of proportion to the type of the exertion? That's the frequency. So you can see these are some of the questions about duration. Is severity and duration out of proportion to the duration of the exertion? So lots of different questions. And then pacing, does the pacing allow you to completely avoid your symptoms? So some people might not experience PEM, but that's because they're pacing, and that's allowing them to avoid those situations. So they might still have post-exertional malaise, they just don't experience it often because they've learned to live with their illness. And the final piece that we ask is physical functioning scale. And this is a standard SF-36 short form medical outcome survey. And it gives us a standardized score so that we can basically relate how much physical functioning they have, and is that related to some of the, Good. So again, that's just an overview, just a little bit of a background. And, you know, I take it we don't have my colleague and research assistant. So I'm going to just real quickly give her a call. And I have a feeling that she might just be thinking that this thing is at 2 o'clock, because but let me just give her a quick call. We'll take a little 10-second break, and I'll see if I can get her on the line. Yeah, Maddie, you know, the thing starts at 1 o'clock, not 2 o'clock. Yeah, just come on. So we're doing it, and I just went through the slides so you can join us and participate in the conversation, okay? Okay, yeah, bye-bye.
So while Dr. Lenny is getting Madeline, I just wanted to ask, I guess, for those of you that are out there, I mean, we're all OTs or PTs, we're a Facebook group, but we are mainly a resource for each other for the ME community and the patients that we more or less help to advocate for. And I just wanted to find out from everybody else, if there are some tools that that you have been able to see with PEM, but then also if you find that a tool like Dr. Jason has developed, how significant is that to the OTPT community? I just want to throw that idea out there.
I think there's been lots of questions. That's one of the standard questions we've been asked. It's Michelle, sorry, from lots of physios, particularly dealing with long COVID, around, well, how do, you telling us to watch out for this thing called PEM, but how do we find it? So I very much said, do a really, really thorough subjective assessment, because of the fact that we haven't got been using this questionnaire. I know that Darren from Long COVID Physio has been advocating for the DePaul symptom questionnaire. So yeah, that's why I'm not here, to learn more about it, and to see whether others have been using it or not.
What would be really helpful is to, I'm not sure, Amy, if this would be appropriate, if I could just hear, who the people here are and what their, people they work with, whether it's MECFS or long haulers or whatever. That would be great, just to, and here's my associate, Maddie Johnson. Welcome to the group, Maddie. I'm glad you
Hi,
could join
hello.
us.
I am so sorry about that. I had 2 p.m. down. I'm happy to join now, though.
Sorry, I'm just to go back and introduce myself then. So I'm Michelle. I'm a physio in the UK. I'm one of the physios for ME. I've got 2 sons who've got ME, and we've also been doing quite a lot of, so we do a lot of sort of advocacy and education for physios around ME and trying to change practice in our profession over here. And then also we've sort of been doing quite a lot of work with long COVID in the same manner, and working with Darren Brown, who's one of the founder members of Long COVID Physio, if you've come across them at all online. So that's me.
Okay, nice to meet you, Michelle.
I'm an OT, and I'm also in Chicago. So I have a child. I have a child who has very severe ME. So we've been actually, I'm trying to find a tool. I know that it comes up very, very often for how do you describe, how do you document PEM, and especially in the OT world, we don't necessarily do measurements like PTs would do with cardio monitoring and things like that. So doing something from a subjective perspective is something that OTs are constantly striving for. When you do activity assessments, when you're really taking history of illness, how do you do it in a subjective method as opposed to actually, really taking quantitative data. So this, I think, is a very nice tool because it goes through that history that hasn't necessarily been brought to the attention of even the person with the condition. They think like, well, this is what I've lived with for 20 years. What do you mean it's not normal? So this is a nice way of looking at it. So thank you.
Yeah.
I'm Sally, and I'm a PT, and I'm one of the co-founders of this particular group. We're kind of focused more on the United States educational focus for the PTs and OTs, ME and CFS, and now long COVID. And I was in practice for 18 years and I'm disabled with ME CFS. And I think the thing for me is one of the big parts of our advocacy and education with this group is to not only teach about the disease, the pathology, but actually how to make clinicians more comfortable with the business of healthcare, which in physical therapy in particular is outcome measures. And so some of the physical therapists that we talk to are just completely stymied when they can't grab their friendly, familiar outcome measure to measure PIM. And so this is a really great step for us to be able to introduce this where they can have their peace of mind that they're not off into no man's land completely.
Mhm. Definitely. It's nice to meet you, Sally.
Hey, I'm Melinda. I'm sorry, Leanne. I'm sorry.
No, it's okay.
I'm one of the co-founders of this group with Sally, and I also have MECFS for over. I've been unable to work since 2002. I'm a PT, and I'm one of those that you may have heard about that have also been diagnosed with EDS and structural issues in ME, and I underwent a fusion a year ago and have seen some improvement with that. And Sally and I started this group because we are also ME patients and we hang out in ME support groups, and we really listened at how unhappy patients were with physical therapy, primarily because they were being asked to do graded exercise therapy. So while we've shared a lot from the Workwell Foundation as far as the physiological aspects of what's going on in the illness, I think this questionnaire is a really good tool to have as well, especially going forward. With long COVID, our group has joined the Long COVID Alliance, and they have already started working groups as far as patient and medical education. And we just want to make sure that some of these long COVID places are popping up all over the world, that they're screening for PIM because a lot of them aren't, so this presentation is very timely. So thank you very much.
Good. I'm glad to hear that. And I know when this instrument was developed, it was taking into account a lot. I know I'm sure Dr. Jason, you talked about that, but a lot of different patient input and feedback. And so it's good to hear that, you see that in the survey as well. It's nice to meet you too, Melinda.
And then I would just jump in here. My name is Leanne, and I'm an occupational therapist, but I have retired. So I'm really kind of out of it now, but I'm a parent, and I have a son who's been sick since he was 17. He's 20. How old is he? 27. Do I have to know this? He's 26. So 10 years. And certainly working on educating medical community, started a nonprofit in Minnesota. I'm in Minnesota. To kind of help educate the group, and then COVID hit us and everything kind of went on hold, certainly for a long time. My first thought with this assessment was how the length of it, and how, like, trying to imagine my son trying to fill it out and going, I give it to him ahead of time, because he would need lots of breaks to be able to do it. So it would be exhausting to do. So I think kind of do something shorter, but I love that you're doing this. Thank you so much.
Leanne, I absolutely agree with that. That was my thought, Michelle, when you said that. But then when Amy mentioned it earlier about how you would ask those type of questions in your subjective assessment anyway, it's sort of, and you might well need to break your subjective assessment down into chunks, but it's sort of like formalizes how you capture the information that we already ask. So yeah, that brought it together for me, I suppose.
Good. It's nice to meet you, Leanne.
I think I'm last. My name is Paula Tanksley. I live in Northern California, and I came upon this 3 years ago by being tested at Workwell Foundation because I am disabled from fatigue, but not through MECFS, through ulcerative colitis. And so I come a little bit different route, and I'm doing volunteer work for Workwell, and I'm just thoroughly delighted to be part of this group because everything you guys are saying is quite true. And I'm one of those PTs that's been very frustrated with not having outcome measures, and have a great deal of sympathy for the ME/CFS community. And so thank you so much, Dr. Jason, for doing this presentation.
My name is Tammy. I'm sorry I don't have my video on. I'm kind of walking around the home to avoid my son. But I was actually introduced to this group by a PT I used to work with. I am an occupational therapist and I do home health. I myself am currently struggling with the long hauler. It's been about 3.5 months. And so going through all these symptoms myself, I've been a lot more interested in reading your guys' studies and becoming a little bit more involved. However, I have seen patients with post-COVID in home health that are struggling with the same things. And so I was looking for more education, and then I myself was out of work for quite some time. And I'm back to work now and just trying to find, using a lot of OT strategies for, like you mentioned, the pacing was a big one for me. I was very active before, very active with my son. He's that special needs. So needed the energy, and that's been a big struggle for me. So I'm always looking to educate myself on additional strategies, but also to use it too for others that I see in the home environment as well. So yeah, thank you for having me.
Good, thank you. And again, just to repeat for those of you who might have come on a little bit later, we have 2 instruments. One instrument is 10 items. It's a brief version. The other instrument is much longer, and it was kind of developed by patients with DePaul University's input. And it's much more complete and comprehensive. They're both publicly available. Maddie has the articles that describe them as well as the scales. So if we can send them to one of you, maybe they've been sent out to everybody. If there's any way of us getting that information to you, we're happy to do so. But as I said, we really wanted to just provide some mechanism to document what we think is probably the key symptom of people who have what's called ME. Actually, ME in Britain and Europe, and in the United States, they tend to call it ME/CFS.
I was going to ask, what do you both see the patient-derived version? What's your optimal venue that you would like, that you had kind of an idea of where that would be used?
Well, for research purposes, we once we developed it, we launched it on my Facebook page and said, here it is, and we had unbelievable hundreds and hundreds of people within days that filled it out. So from a research point of view, that's fantastic, because that's like money, data. So we've already written up an article that describes some of the psychometric properties and the descriptive properties of that instrument, and that article is available. That we will somehow make it available to this group, but it's free. But in terms of for clinical care, I would say probably what you want to do is, if you have people who you are wondering about whether they have PEM, you could give the brief version. If you've got the brief version, that tells you something, that tells you a little bit, but not the complexity of all the types of things that can be triggers, or all the types of things that can be symptoms, or all the types of consequences, or how one negotiates it through pacing. All these things are much more intricate. So in a sense, what they could be done is, if you're working with somebody and you want to really know a much more complete kind of sense of who this person is and what their challenges are, then I would have them fill out the more complete version, so that can help guide one's PT or OT work with that person.
I really appreciated, like in the article, the reference, like, my experience was I was able to do the 2-day CPET with Workwell and got extensive information from it. But one of the things that I see in talking with clinicians and then patients too, exactly what you guys described in the paper. It's only for the moderate to minimally affected, and then you have to have the ability to travel and the income to pay for it. The other thing is that very often physicians will order functional capacity evaluations for ME/CFS patients, which, unless the clinician that does the FCE follows up to document PEM, the FCE can be completely, can completely undermine somebody's ability to qualify for disability, because they can look good at that moment and not capture the PEM and the consequences later. So I was really thinking about it as a replacement for the FCE, and being able to use it over a longer period of time with a clinician to, because if you're applying for disability, it's no short window. And that way you could have a long-term self-report and monitor that, and have a really fine-tuned document that is submittable to the disability organizations.
Yeah, I think having, self-report questionnaires that could be given at several times, I think could be information that I think could be particularly helpful when these types of decisions are made. And it's not like it's not validated. It is now validated and it's been published. So you've got some credibility behind the instrument, which is a good thing. But if you're doing a cardiopulmonary test, or if you're doing other types of biological measures, I think that the biological piece is also extremely important to, kind of get people behind your kind of particular cause, which whether it's disability or other things. But, I think going forward, there's going to be a lot of different ways of documenting some types of, problems. And like in our lab at DePaul, we work with Mark Zinn, who's just got his PhD at DePaul. And we look at the brain, and we use quantitative EEG, and we give a little stressor, which is kind of hand grip. And that hand grip triggers all types of brainwave changes that we can document. So if we can do that in 3 minutes and make it something that is not going to necessarily be impairing for the person, why not? I mean, let's collect as much information as we can that basically is helping in determinations of, whatever the person needs.
I have a question. Could this be used like with a primary care physician? Because it's like, so that over time they can have documentation about problems.
Yeah, and I might add that for those of you, we've just actually written an article that is not published yet with two physicians, Lily Chu, Eleanor Stein being two of them. So, and Megan Elliott at my center, myself. And it's on suicidal ideation. And you'd be surprised at how many patients who are dealing with ME/CFS or long haulers have had suicidal ideation. So primary care is the place where you're going to hear it. You're not going to hear it from psychologists and psychiatrists. People generally aren't going to them and saying, I think I'm suicidal. Where it's coming out is at the primary care clinics. And at the primary care clinics, you're going to basically hear complaints of PEM. That's where you're going to hear it. So outpatient primary care, that is the big net that you want to get something to assess person's functioning. Make sure that they're not going to do anything to themselves because this is a pretty debilitating thing. And if you basically don't have a strong sense of belonging, and you don't have, in a sense, of, feeling like people care about you, and you don't feel like there's a reason for being, and you've got a lot of pain and sleep problems and PEM, that can be very detrimental. And we should always be thinking about that when we're dealing with patients. But for a quick screen to basically help a physician or healthcare worker who is trying to get a sense of, I don't get it. It's like, I exercise and I feel great. That's what everyone does. It doesn't happen with you. And they don't get it. Truthfully, this is a society that is energy kind of sort of addicted. So if you don't have energy, you're in big trouble, because this is the Protestant work ethic. In a sense, everyone should be able to get out there and solve their problems. And if you can't, then you're in big trouble. And energy is really important. And if you've got post-exertional malaise, and you come in to different settings, work settings, healthcare settings, and others, you are labeled for a variety of things. So if a clinician wants to help that patient, having a sense of their limitations and having a sense of their experience is incredibly useful. And what experience is more important than PEM? I mean, that's it. I mean, sleep difficulties, absolutely, incredibly important. Cognitive problems, absolutely, very important. But wouldn't you believe it? PEM basically causes both of those things. So if you basically exert yourself too much, what do you think is going to happen? Your sleep's going to get busted up. You're going to start having pain. You're going to have cognitive confusion. So that's why PEM is so central to all these different pieces that occur with patients.
Well, I think, like I saw also with having a primary care be able to document it over time, kind of goes in if you're applying for disability, and that takes a long time to do. And with our son, he was denied, and one of the things was that all the visits with the primary care said that he was disabled and unable to do things, but there was nothing documented. There was nothing to prove it. It was just his word. So that would be like a perfect tool to throw in there to have a longevity marker for him.
Yeah. I think one of the things that's key in developing a questionnaire for PEM is really looking at those triggers, but also the duration. The duration component's really important, right? And the longevity of that and how it comes up. And I think, just like with, COVID, loss of taste and smell, that's a very hallmark symptom of COVID. PEM is a hallmark symptom of ME and CFS. And so to be able to identify that and to use it in the primary care setting, I think is really important.
I just want to point out, I think Dr. Jason had said this a while ago, that if you ask any person with ME what they want to do, they will give a huge list of activities that they are wanting, but of the depressed, a person with depression is probably not going to have that answer. So that I think is kind of marks that there are so many things that people have in their dreams and in their bucket list that need to be validated to say, like, it's really important that you keep those ideas, and that PEM, by documenting this, can really validate that those are really true desires for you.
So Amy, besides substance use, depression is like the most prevalent mental health problem. So your primary care people are getting lots of folks coming in with depression, anxiety, and they sort of look at them one after another, and eventually they kind of say, well, take a vacation, go to a psychologist, take some antidepressants. So they get their usual battery of saying these are things that help most people who have depression. But the reality is, the people who are coming in, the long haulers, they might actually be depressed because of how they're being treated and the fact that they're not seeing improvements and they don't know what to do. But that depression that they might experience, or the ME/CFS person might be disillusioned and might have a feeling of overwhelming kind of like oppression, but that's different than the anhedonia, the depression that a solely depressed person has. And yet those solely depressed people are the folks who primary care primarily see. They see lots of them. They see lots of anxiety and depression, and particularly these days. So making the distinction, differentially being able to diagnose is so critical. And our primary care physicians and healthcare workers haven't been trained to do that.
Yeah, and I think, we're seeing it, we've seen it with ME and CFS, and now we're conducting a study at the center with COVID long haulers. I'm actually working with pediatric COVID long haulers who say that, across the board, they go in, and I feel like sometimes in medical care, if there's not a specific test that can be ran, blood work that shows, exactly what's wrong, it oftentimes is brushed off as a psychological thing that's going on, and that can be incredibly damaging to yourself and then treatment outcomes. And so, yeah, having that piece that really differentiates someone who has, chronic depression from some of the symptoms that are really hallmark to ME/CFS is really important, I feel.
Yeah, I'd agree. Oh, Amy, you're on mute. No, I was just going to jump in and say, as a physio, one of the things, I think there's been some quite interesting discussion on social media about this whole exercise is the thing we do, and therefore that some physios can't seem to get their head around the fact that it's not the right thing to be doing for a cohort of people. So actually being able to use the questionnaire to sort of tie it together, and also that whole thing around the delay in PEMS sometimes, I think, is the challenge, because also as physios, we're quite used to sort of delayed onset muscle soreness the next day, but that sort of 48 hours or even longer, 72 hours, it's a whole new thing, isn't it? And somebody said earlier, we don't learn about it. We don't learn about it in physio school. We don't learn about it in any sort of follow-on learning. I think all of us around here have learnt about it through our sort of personal involvement, haven't we? So yeah, it's a challenge.
Yeah, I know, Doctor. Sorry, go ahead, Sally.
No, I was gonna jump off that and kind of go a different way. So please finish. Sorry.
Oh, I was just gonna say, Michelle, that's so true. I think even before I started working at the center, I know Dr. Jason, you all have an article out that says the specific percentage of times that ME/CFS is even brought up in medical textbooks. So physicians, OT, PTs, it's not. It's definitely not taught across the board as it should be. I don't know I forget what percentage that was, but it was a lower percentage.
Yeah.
We surveyed the physio schools in the UK, and less than 50% of them actually do something, and some of them it's like 1 hour maximum. So it's yeah.
So I'm not even sure how to formulate this question, but it's something that comes up repeatedly in our group as a confounding issue with therapists who are trying to navigate ME/CFS with the comorbid conditions of POTS and hypermobility. But in doing your study here, you looked at MS and post-polio. Would there ever be a way that you could think of that you could adequately use this to differentiate pure POTS versus, individual with ME/CFS with orthostatic issues, and pure hypermobility versus someone with confounding hypermobility and ME, to help, differentiate those two or three?
Well, it's interesting that the NIH just came out with a notice of interest for orthostatic intolerance, and so they're interested in I guess grant proposals for folks who have some of these orthostatic intolerance issues. So could the questionnaire that we developed be used to differentiate those three groups? Absolutely. And if we had you know, enough individuals, we could certainly do that. So yeah, I think that would be a good study.
It seems to just almost immobilize therapists, the thought that they are potentially treating like a POTS patient who can benefit from regular exercise, and they're mistaking them for an ME patient and under exercising them. And so then they just don't do anything. You know?
So what we're saying, which is actually very interesting, is that diagnosis is critical, that you've got to decide who you're treating. And if you don't get that right, the whole treatment program becomes errant. But it's not just a treatment program. All research becomes errant. So in some ways, if you have like a house of cards, that bottom basic level is your diagnosis. Who has it? Who doesn't have it? What illness do they have? And if you don't get that right, then the etiology, the epidemiology, the understanding genetic factors, predispositions, predisposing factors, and treatments, everything gets mushed. And guess what? What do you think our field is? Complicated, difficult, contradictory, often because we haven't spent enough time trying to basically get that definition right. And the basic diagnostic work isn't funded, it's hard to get published, and that's what science is about. And in this field, we've decided to skip that stage. You know why? Because a lot of people who are healthcare workers, particularly physicians, basically say, oh, I know it if I see it. That's what they say to me.
Well, I hope you'll apply for some of that money.
Well, there's you know, certainly that would be an interesting proposal. We are writing a couple grants right now, and we're hoping to you know, get a couple grants into the hopper over the next couple months.
That's great.
And have you done, because I mean, I know that your history has been so involved with defining the disease and writing about that. Is that an area that you feel just still needs to be targeted, and or do you think that the information is out there and it just needs to be revisited? I don't know if I'm breaking up or not.
So I've only been working at this for 30 years. And I've been saying the same thing for 30 years, talking about what it means to make a diagnosis, what it means to make a case definition, what is liability, what is validity. I've been writing about it, you know, so the only thing I can do is keep saying this is an important thing that we need to do. If nobody listens and nobody cares, I can only do as much as I can. But the reality is, that's the problem.
I share your frustration, or I feel and share your frustration, even though I haven't been in this arena for 30 years. And I think it's one of the things that I'm sort of clinging to about one of the only positives of COVID is that it's actually putting this more out there and people are more aware around post-exertional malaise and want answers, and that's only going to help, isn't it? And I think that's, as I said, you have to hold on to see the positives in everything, and that's about one of the positives from COVID in my book. So yeah,
even you know, the director of NIAID, National Allergy Infectious Diseases, is Fauci, who is really pretty prominent. I mean, he has publicly stated that long haulers exist, and if you look at his comments for many decades before this, it would be very different statements he was making.
Well, our chief medical officer came out early on in lockdown and said there's no condition that exercise isn't good for. And then we were all like cringing and banging our head on the table, and we've written to him to say, retract it. But obviously it was right at the beginning of wave 1. And he hasn't said it since, interestingly, though. So, yeah.
Well, again, you just need to realize that exercise for healthy, normal people is probably about the best medicine. There's more research on that.
Absolutely.
And so we know that the first line of defense is get people to become more active. And it works for just about everyone. And then there are those exceptions where that advice to go to the gym 3 times a week and you'll feel better, come back in 2 weeks and I bet you'll be fine. It doesn't work with this illness.
I know.
Has Marcy Zinn's department been able to pick up some of the work since her passing? I know that it's a terrible loss for the center, but she was doing such magnificent work with her brain studies. Has some of that been picked up?
Yeah, well, Mark Zinn, which is her husband, you know, he's continuing to do work in this area. So we're actually, yeah, sending some manuscripts out right now.
With this having had all the discussion we've had, is there anything that either of you would like to additionally communicate directly with the PTOT world?
I just applaud, you know, in a sense, those who want to learn. I mean, I think that there's nothing more important than being open to thinking differently. Probably most of their training is going to push them into things that are relatively unhealthy, unhelpful for people who are, you know, dealing with ME/CFS and long haulers. So they need to be open to thinking about a very different way of working with patients. And those that do this will be the heroes. Those who do this will be the champions for change. Those who are willing to take a risk and try something different than their instructors and textbooks told them are going to be the folks who are going to be the Florence Nightingales for the 21st century.
Yeah, I would piggyback off that. I applaud you all for learning more. That's always great. I think also just, and I mean, you all know this, but no one patient is the same. That goes for any illness, but especially this one. And, you know, hopefully what's being developed right now, and especially regarding PEM, can kind of help guide that a bit more. Yeah.
That's very helpful.
Yeah, well, I want to thank you for all the work that you are doing at your clinic, at your center, because you guys are the brains behind all of these ideas, and you're actually putting it down on paper and writing about it. So I just want, from our group, I want you to know that we are trying to take up your tools and put them to use and spread the word, because I know that you aren't supposed to necessarily promote your materials, but by educating us, I hope that we can take it to the next level to get it to the provider's hands for you, because these tools are what our children need, our friends who have ME. You know, there are a few of us that are parents that are trying desperately to change the world for our children who have ME. And this is exactly the tools that we need to use as advocates and as healthcare professionals. So, so from us to you, please keep doing what you're doing, and we'll help you all the best we can, because this is what needs to be done.
And just again, add, thank you all for inviting us. We're humbled by your kind of positive response and feedback for us about what we do. And we very much appreciate that we're playing a constructive role. We do have two projects that we are collecting data on now. One is with the pediatric long haulers and the other one with adult long haulers. So Maddie has links to those things and she can send them out. So if you know people who either have youth or themselves who have been affected by this, you can have them think about, our study. We're using a modified version of the DePaul Symptom Questionnaire, so we can compare the long haulers with people with ME/CFS.
Mm-hmm. Yeah, and feel free to let me know if there's an email that works best for me to forward those links, and also any articles that we discussed. I'm happy to do that.
Yeah, go ahead and send them to me directly.
To you? Okay,
yeah,
perfect.
Yeah. Send them to me and then I will get them on the Facebook group for everybody in our group to access. So absolutely.
Great, I'll do that.
And thank you so much. And, this recording is great. I'll share this with people at my center and others. So we can just keep getting the word out.
Fantastic. Thank you so much.
Thank you.
Thank you all.
Thank you very much.
Thank you.
Bye.
Thank you.